Hello, my name is Dr. Roger Henderson, and I'm a GP working in southwest Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, and many of you are telling us that you do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can follow me there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings which occur all year round. Now, in this episode, I'm going to be discussing croup, and I think it's very appropriate to be discussing it at this time of year because, as we all know, the autumn and winter months tend to be the peak season when we see people with croup, although it can occur any year round. Now, croup, or laryngotracheobronchitis, to give its more formal name, is a common paediatric condition, as we all know, typically affecting children between 6 months and 3 years, but peaking in the second year of life. Now, it's slightly more prevalent in boys than girls, and as I say, tends to occur more frequently in the autumn and early winter months, so around now. The illness is due to viral infection, typically parainfluenza virus types 1 or 3, but other viral pathogens have been recognised here, including influenza A and B, adenovirus, RSV, and COVID, and rarely measles has been reported as triggering it as well. Now, here in the UK, croup accounts for about 5% of respiratory illnesses in children, with most cases being very mild and self-limiting. Now, distinctions have been made between what we may call viral croup and spasmodic croup, but it's actually quite unclear as to whether these entities represent different diseases or are merely a spectrum of the same disease. Now, for me, this doesn't matter, as it's difficult to distinguish between the two clinically, and also, I think, unnecessary for the simple reason that treatment decisions are based upon the history and the clinical severity of the airway obstruction, regardless of what we choose to call the type of croup present. Now, as we all know, the key features of croup are the characteristic sudden onset seal-like barky cough, which once you've heard, you'll never forget, often accompanied by stridor and sometimes intercostal recession or sternal indrawing. Now, symptoms are typically worse at night and undoubtedly increase with agitation or the more upset the child becomes. Now, there may well be a history of previous non-specific upper respiratory tract symptoms shortly before the croupy symptoms develop. So I'm talking about things like a mild fever, coryza, a non-barky cough, although I have seen cases where the seal-like barky cough may present abruptly with no preceding illness. Now, although it's not essential to the diagnosis, you may also commonly see a hoarse voice in the patient. Now, if stridor is present, then as we know, this indicates narrowing of the upper airway, and so we can gauge the level of airway obstruction according to the severity of the stridor. Mild croup typically only presents with stridor during activity, but not at rest, while severe cases, on the other hand, do show stridor at rest, along with things like increased work of breathing, cyanosis, and fatigue, or signs of hypoxia, in other words. For me, I've always liked to use the modified Wesley clinical scoring system for croup, and this looks at a number of points with each of these being scored. So we look at inspiratory stridor, we look at intercostal recession, we look at air entry, we look at cyanosis, and we look at level of consciousness, and we score each of these. So, for inspiratory stridor, if it's not present, that scores 0. If it's present when agitated or active, that's 1 point. And if it's present at rest, that scores 2. If intercostal recession is mild, that scores 1, moderate 2, and severe 3. If air entry is normal, that does not score at all. If it's mildly decreased, that scores 1. If severely decreased, that scores 2. If cyanosis is not present, again, that does not score. But if it's present with agitation or activity, that scores 4. And if it's present at rest, that scores 5. If the level of consciousness is normal, that does not score. But if it's altered, that scores 5. So if you've been following that, you can see there's a total possible score of 0 to 17. Now, below 4 would be classified as mild croup, 4 to 6 is moderate, and over 6 is severe. So let's have a look at investigations. And I'm sure you're like me, for the vast majority of cases, we diagnose croup in our surgeries clinically, and investigations aren't usually required. And I certainly wouldn't be doing a routine chest x-ray unless I thought there was an alternative diagnosis to explore, thinking of things like an inhaled foreign body, epiglottitis, or even bacterial tracheitis, for example. But you might remember from your medical student days that in severe or atypical presentations of croup, a lateral neck x-ray may show the characteristic steeple sign that indicates subglottic narrowing. However, as a general point, chest x-rays aren't routinely performed. And I'd remember too that radiological studies are contraindicated if there's clinical suspicion of epiglottitis or bacterial tracheitis, because manipulation of the neck region along with agitation may precipitate further airways obstruction. However, using pulse oximetry in your surgery may well be useful in moderate to severe cases, since this can help to assess the oxygen saturation of your patient in front of you and guide you as to whether supplemental oxygen may be needed. Now, when we're treating a child with croup, care must always be taken to avoid frightening the child. Agitation may cause considerable worsening of the symptoms, as well as causing increased anxiety for the parents. To ensure comfort, the child should be seated comfortably in the carer's lap during assessment, and especially in mild croup, parental assurance and education about the self-limiting nature of the illness is very important. Now, fortunately for all of us, most cases of croup are mild and can be managed nicely at home with reassurance and supportive care, such as ensuring adequate hydration and using antipyretics if required. Now, historically, mist or humidified air has been widely employed in the treatment of croup, but there's now good evidence that these are ineffective. In general, the mainstay of treatment for croup is corticosteroids, which obviously help to reduce airway inflammation and improve symptoms. And in one Cochrane systematic review, corticosteroids were found to improve symptoms of moderate to severe croup within 2 hours, with the effect lasting for at least 24 hours. Current UK guidelines recommend oral dexamethasone at a dose of 0.15 milligrams per kilogram as first-line treatment, with a possible alternative, if need be, being oral prednisolone at 1 to 2 milligrams per kilogram, although I have to say dexamethasone is preferred due to its longer half-life and greater efficacy. Both oral and intramuscular routes of administration have been shown to be equivalent or superior to inhaled corticosteroids in moderate to severe croup. And also, if we're looking at moderate and severe croup, nebulised epinephrine should also be administered with dexamethasone, as it provides temporary relief of symptoms of airway obstruction. We should see a clear reduction in stridor or sternal or intercostal recession within 10 to 30 minutes following administration of that, and the clinical effects of nebulised epinephrine last on average at least an hour, but then usually subside about 2 hours after administration. Now, hospital admission is warranted for children with severe respiratory distress, stridor at rest, or in those who don't respond to initial medical treatment. And if oxygen saturations are below 92%, that should trigger that along with the administration of oxygen. Now, fortunately for everyone concerned, the prognosis of croup is generally excellent, although we've all seen the stress and disruption experienced by a child and their parents during an episode of croup. Most children typically improve within 48 hours, with symptoms peaking in the first 1 to 2 days and resolving within a week. But undoubtedly, the use of corticosteroids has significantly reduced the need for hospitalisation and the risk of serious complications. And since combination treatment with dexamethasone and nebulised epinephrine became standard care, for the prognosis for even severe cases of croup has become excellent. I have to say, in my experience, recurrent croup can be common, with some children having repeated episodes over the course of months and years. Now, recurrent episodes that are particularly severe or frequent, or croup symptoms that take an exceptionally long time to resolve, or most importantly, symptoms of airway obstruction that persist between episodes of acute infection, do warrant further investigation. So thank you for listening to that brief podcast about croup, and I hope you found it helpful as an aid memoir the next time we see one of our cases over the coming weeks and months. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Do feel free to get in touch via social media at GPnotebook, or email us support@GPnotebook.com if you've any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But as always, thank you for listening, and until the next time, goodbye.